We're moving to the second half, and this is the part where we're going to hear about, I guess, a story from South Africa, which illustrates, in terms of a care system, really where, I guess, love and care is not enough. And we're going to hear from Dr. Tracey Naledi. Welcome, Tracey. Great to see you.
Hello, everybody.
We're sorry that you're not here in person, but obviously we hope to catch up with you later in the year, in May, when we visit you in your hometown in Cape Town. So Tracey is calling in from Cape Town, South Africa. And Tracey Naledi is a Deputy Dean of Health Services at the University of Cape Town in Cape Town. She's also a board member of the governing board for the Global Brain Health Institute, and she was a founding director for Takano. And Takano was a sister Atlantic Fellows program. It's an Atlantic Fellows program for health equity in South Africa, and Tracey was there at the very, very beginning as the founding director. And we're very excited to have you here with us today in Dublin. And I'm going to hand over to you because you're going to tell, I think, give a kind of a case study really from South Africa, which really is it's really tightly linked to this theme of where love is not enough, and it's in the mental health space. If you can give us the case study, and then there's an opportunity for John Farrelly, who's the CEO of Mental Health Commission here in Ireland, and also we have Siobhán McArdle, who is Assistant Secretary for Mental Health, Drugs, and also for unscheduled care here in the Department of Health. They'll have an opportunity to respond, and then we'll be able to open it up to a panel discussion and involve the audience. So over to you. Thank you very much.
Thank you very much. Wonderful. I greet you all from the Faculty of Health Sciences here at the University of Cape Town, which is situated in a town within Cape Town, a suburb within Cape Town called Observatory, which is at the foot of the mountain that you can see just behind me. It's at the foot of Table Mountain and Devil's Peak. And Observatory takes its name from the South African Astronomical Observatory headquarters that was built here in Observatory in 1829. But it's a place of the stars. Even it was recognized as a place of the stars even before 1829. So we call our faculty Endaweni yezinkwenkwezi, which is isiXhosa, Disterewag, which is in Afrikaans, and Klamerodichais, which is what the first people, the Khoi and San people who first inhabited this land, would have called it. And they tell us that where this land is, which is where the Black River meets the Liesbeek River, is a very sacred land for them. And they tell us that this is where they themselves first discovered the place of the stars, and Klamerodichais actually means a place of the stars. It's a place I often imagine what it could have been like then, and I imagine them looking up into the sky and gazing into the bright stars and really unraveling the secrets of nature that allowed them to traverse this land, dreaming of the pride and joy of future generations who would live in this land with peace and freedom and in deep connection to one another. I think they dreamt of this very day where I'm connecting in all the way from Cape Town, all the way to Dublin. And I understand there are many others around me from around the world connecting together in conversation. How amazing is that? Not just in conversation, but in passion, in love. And I think very much like the stars that are here in Klamerodichais, collectively, our own brilliance outshines the sum of our individual strengths and our contributions. I'm a Zulu woman woman, which is one of the tribes here in South Africa. And this notion really resonates with me. And in my language, we have a saying that says, "Ngingumuntu ngabantu," meaning I am because you are. So we are all connected in our humanity. So I'm very grateful to Dominic and Brian to invite me to be part of this conversation. And I'm sorry that I couldn't be there in person, but I'm grateful for the opportunity to at least share some of it with you. So, what is love? And I think many of us can have many definitions of what love is, but I think what we can all agree is that love is shown in our deeds and not only in our words. When we just speak about love, I think that love is empty, and it's love that is not one that we can count on, so to speak, in our lives. I am really intrigued by this definition of love that comes from Dr. Martin Luther King, who positions love as implementing the demands of justice. I must say that really, really resonated with me, and speaks about power at its best being this love of implementing the demands of justice, and justice at its best being the power of correcting everything that stands against love. I was really intrigued by this definition and what Dr. Martin Luther King, and so I'm hoping that in the story that I will tell you just now, it's a story that will show when this kind of love was love and when it was not. So I'm going to be telling you a very sad story about a place called Life Esidimeni, which was a mental health facility in South Africa. But before I do that, let me tell you a little bit about South Africa so that you can contextualize my country. So South Africa has a population of 62 million people. We have largely a young population. The median age is 28 years. About 38 million people are above 35 years. We are mainly African people, Black African people. More than 80% of us are Black African people. Multilingual. There are 11 official languages, and many of us speak 2 or 3 languages. We are upper middle income country, and our own government spends quite a significant amount of money on health, 3.4 billion rand in health. What you might know about my country is that we suffered apartheid, where the minority, which were largely white people, ruled over the Black majority in quite oppressive ways. And in 1994, we received our freedom and had the new South Africa. So if I hone in a little bit in terms of how our health system is structured, 84% of the people of South Africa are dependent on the public health system, and the small minority, which is the blue that I've shown there, have private medical aid. And what is interesting about my country, what you can see there, I'm not sure if you can have a clicker, but if you can see there, I hope you can see it, but I'll translate it to you if the slides are too small for you. The private contributions make up almost as much as what government kind of spends on the public on the public health system. So serving a small minority of the population. And what is interesting about that is that that small minority, which is 16% of our population, is still largely of the previously white and Indian race, as we put it, as we call it here in South Africa. Even though we know that race is a social construct, but many of the dimensions of when you would describe population are still very much. You can still see a racial distribution in how these are. As you can see here, the minority white population largely uses the private sector and has private contributions. And what's interesting about this is that even though that 16% will have a private medical aid, about a third of people would still use the public sector, particularly for primary healthcare facilities, primary healthcare services, and the vast majority of, and also for mental health services in particular. So, there's a lot we can be proud of in my country. And I don't want to just provide a doom and gloom story, because really there's a lot we can be proud of in my country. In my country, we have had a significant increase in people receiving social support. About 12 million people have a really good safety net that they can have if they don't have jobs or income. We have free education. We have a wonderful free school nutrition program. We have basic services that people didn't have before. So there's a lot that we can be proud of. And also from a health perspective, we have had improving health outcomes with reductions in infant and child mortality, with increasing life expectancy. What you can see there on the life expectancy, you can see that we had an initial drop in our life expectancy in the 90s, which was due to HIV and the fact that our government of the time, and President Thabo Mbeki, who was a president at the time, was a HIV denialist. He didn't believe that HIV existed, so did not approve government to provide ARVs. We had to go to constitutional court. NGOs had to go to the constitutional court for ARVs to be available. And largely as a result of HIV, we had ARVs for treating HIV. We then were able to increase our life expectancy. What's very interesting is that last little bit, you'll see that we've had a 3.5-year reduction in our life expectancy, which was due to COVID. And if you trace back, that takes us back about 15 years or so, in terms of it has taken us 15 years to get to this point. And just COVID, with literally just one pandemic, it really reduced our hard-earned improvements in health, which I think for me emphasizes the importance of social determinants and what it is that they do, and how fragile they make the gains that we've had. As I said, even though we have a lot to be proud of as South Africa, we still remain the most unequal country in the world. And this inequity persists and has been exacerbated since 1994. So even though on average, which is that solid black line that you can see between those blue and those red lines, even though on average, as South Africans after 1994, after our freedom, on average, we've done well. But when you disaggregate this data and you look at in terms of the top 1%, the top 10%, the middle 40%, and the bottom 50%, what you can see there is that when the top 1% has increased their income by almost 50% since the dawn of our democracy in 1994, the poorest, which is the bottom 50%, have actually reduced their income by a third. So on average, even though we've done well, there's still a lot of inequality, and that persists, particularly for the poorest of the poor. And mental health in particular, as you know, is one that actually exacerbates poverty as well, has this vicious cycle as well. So I think it's quite relevant in this context. We've done well in terms of reducing the burden of disease. We have what we call the quadruple burden of disease. The top green one is violence, and then we have non-communicable diseases. That red bit there that you can see is HIV, and you can see that we've had a quite an interesting reduction. What's interesting to look at, which speaks to these social determinants, is that bottom bit, that purple one, is kind of those diseases of poverty, malnutrition, etc. And the green, you can see that we haven't had much of a shift in that, which I think speaks to the overriding social determinants of health that very much we're really struggling to get over because of the inequality that we face. So with regards to mental health in particular, um, um, I really liked this article, the headline of this article, because I think it really speaks about this notion of love. And there's an article by one of the activists, Mark Haywood, who wrote this article during COVID when he was talking about the South African mental health epidemic. Love don't live here anymore. And I thought it was quite apt for when I found this headline, and it reminded me, and I thought it linked quite well with this conversation. So in South Africa, in the most recent mental state world report that was released, we didn't fare so well. We were ranked the lowest in terms of our mental health quotient, and the highest in terms of the percentage of those who were stressed and distressed out of 64 countries. Our Department of Health spends about 5% of its total public health budget. That one that I showed you, they spend it on mental health care, but where they spend it is largely with severe mental health disorders and hospital care. So the public sector in particular has a grave shortage of mental health professionals. The WHO has noted that we have 0.4 psychiatrists per 100,000 population. And there's huge disparities between provinces, with the urban provinces. I'm in the Western Cape, which is one of the better resourced ones. And really, what we know for sure is that most people who actually require health services, mental health services in particular, don't receive them. And never mind inpatient services, but community-based services as well. Our community-based services are underfunded and undercapacitated, even though we know that caring for people who with mental health disorders works quite well in communities, etc. But you can't just send them out into the community without much care. Which just hold that thought. I'm going to come back to that point in a minute. And if you look at where we are globally, France, Norway, and Germany are apparently the three countries that spend the highest in terms of their mental health care, or health budget on mental care. And from what I've read, also largely within hospital services. And what I found very interesting is that if you look, for example, France is not looking much better than South Africa, even though they're spending so much more in terms of mental health services. And to me speaks that perhaps where we spend the money is as important as how much we spend, and thinking very much around where we should be spending it within communities. That graph on the right speaks to some data that comes from one of our medical aides that was looking at what proportions they were paying their claims on, and you can see that dementia, even within the working population who have medical aid, was about 10% of kind of mental health disorders that were being funded. So to the story of life esidimeni, and I've purposefully not shared any photographs or anything with you, because this is a very, very sad story, and if you look online, you will find some of those horrific photographs, but I've chosen not to share those photographs, respecting the families and those who have felt the consequences of this horrible saga in my country. And I think it tells the story of the cost of not caring or of not loving. So what happened is that in October of 2015, in one of the provinces, Gauteng, the health department announced that it would terminate its outsourced care contract with a private healthcare provider called Life Esidimeni, which had been providing specialized psychiatric care to state patients, particularly those with long-term conditions. And the provincial minister at the time, who was the Dani Masang, who was the political head of the Department of Health, her reasoning for terminating this contract was to save money. And she says that she wanted to enact the policy of deinstitutionalizing patients into the community, which in itself is a good thing to do, but I think it's important how you do it. When she made this announcement at the time, NGOs, non-governmental organizations, professional bodies, the community and family members themselves tried to warn the department that even though this is a laudable objective, the community-based services were just simply not ready to receive these patients, and the NGOs where these patients would be sent to would not be able to cope with these patients. In March of 2016, the family members of the patients that were staying at Life Esidimeni, they had created an association to deal with some of these issues. And they took the government to court and requested an interdict from the court to say that the province may not move their loved ones from the private institution. The department, however, avoided this interdict by basically making promises to the court that they later dishonored. And between March and June 2016, in a kind of period of about 3 months, about 1,500 and some reports even say up to 1,700 people were moved in a space of 3 months. And they were moved to NGO facilities that were not ready. And just to give you a sense of the rate of transfer, and the rate of transfer in 2015 had been 13.3 patients per month that were moved, and this moved to 456 patients per month during this 3-month period. And the scale and the speed of the transfer was exponential and really not possible for NGO sectors that were not prepared, not well capacitated to deal with this. Patients were transported to these facilities. Some of them were unlicensed. Some of them had fraudulent licenses. They didn't have skills or resources. And in fact, the former Deputy Chief Justice Dikgang Moseneke, who was providing arbitration over this case, awarded in 2018 awards to the families, and he described the events that happened in that 3 months as a harrowing account of death, torture, and disappearance of utterly vulnerable mental health care users. The family members of the deceased reported that they had seen their family members walking around naked. There were stories that patients were being transported in the back of bakkies. Some of them, because they were confused, had been tied up. It was really horrific. And Judge Moseneke awarded the families 1.2 million each as compensation. This is probably one of the biggest cases that we had here in South Africa, and one where, in fact, families did receive some kind of compensation. However, even though the families, I think, appreciated the awards and the compensation that they received, I think the biggest gripe that they had is that their fight for justice meant that there had to be some kind of accountability within the system, and that there had to be some kind of reform, and that had not really materialized. In September of 2019, the National Prosecution Agency said there was no sufficient evidence to lead to a prosecution, instead launched an inquest. The Gauteng Department of Health then adopted a mental health care strategy, which was meant to improve to reform mental health services within Gauteng, but due to COVID and due to other reasons, that really never materialized. And so what then really happened is that these families were left, yes, and like 1.2 million rand might be a lot of money, but it does not bring back your family member, and it does not prevent it from happening to other people. The South African Human Rights Commission launched a countrywide investigation looking at other provinces and trying to make sure that Life Esidimeni did not happen in other places. And what they found is that we have a prolonged and and systemic neglect of mental health services, and that the policies were not implemented as they were meant to be. So, I mean, I think this is a continuing story, and I think our mental health services in South Africa remain weak, and they remain needing strengthening. But really, I just wanted to talk about this story in view of. In view of what it is that we are talking about in this conference, and talk very much about this notion of love. And I want to go back to my definition of love that I alluded to from Dr. Martin Luther King. And I think from the family and community perspective, I think for me, the story tells of the love which is demanding justice. So family members, community members were demanding justice for their family members. But the power, which is the system, just did not respond. The power was meant to provide justice by ensuring that it corrected everything that stands against love. Um, and in all of that, one of the issues, and I think when I look, for example, in terms of the community of Atlantic Fellows, when we think about one of the attributes that we are trying to foster is that of leadership, ethical leadership. And I think one of the things that we can say here is that there was no ethical leadership. And that when we think about leadership and we think about all the attributes of it, it was not present here. And I think in my country, many researchers and commentators have tried to understand what some of the challenges are that pertain to our inability, for example, to implement some of the policies, and leadership has come front and center as one of those attributes that has been seen to be weak. And not just leadership, but management, governance, and being able to hold people accountable. And I think for me, this gives us, when we consider, for example, primary health care, I think for me, that is a promise to correct the injustices. And when I say primary health care, I'm taking it very much from the WHO definition of what primary health care is, saying, yes, it is very much around those health services that are provided for those that are in need, that are closest to the community, that are closest to their home, that in fact are not just primary care services, but that are connected to the broader health system, that you can send patients to if they need other specialist levels of care. But speaks very much that that is not enough, speaks about the need for empowering individuals, families, such that they can be a partner in the co-creation of solutions that are relevant for them. And I think for me, that is love. If you can provide a solution that is relevant and contextually appropriate for me, you are advancing my dignity, and therefore you are showing me love. And this understanding also that it goes even beyond that to say that actually you need to address some of those structural determinants that prevent me from being healthy in the first place. And I like this definitions, this kind of picture, which is from data in the US and may not be the same in every single country, that basically says we put so much store on healthcare services, and when we speak about mental health in many countries, on hospital care in particular, yet that only contributes to about 20% of what will make you well. If you consider that actually the other 80% is outside of the health system. 50% of it being where you live, where you grow up, those kind of social determinants of health, and then other 30% in terms of within your family and within that context. So I think that you understand why I'm saying that for me, primary healthcare approach and the understanding of primary healthcare in these three dimensions for me is a promise to kind of correct injustices. And with that in mind, I think in terms of the opportunities that this gives us as a community, in terms of health system strengthening, certainly in my country, we are working, for example, around health financing reform, working on the national health insurance, but understanding that that is really not the only thing. As I said, we require a health system that has the backbone of primary health care, but has all the other bits of information technology, etc. But the governance of this health system is as important, with leadership being particularly important, but understanding that, we are not going to be leading over people. As a health system, we need to be collaborating with those that we serve, such that we can engage in health services that are relevant and contextually appropriate, that people themselves can feel they've been a part of co-creating with us. And we as health workers and health managers and health leaders can go back to the communities and have social accountability and be able to account on all the things that we've done, and focusing very much on the things that matter to people. And I think globally, the whole notion of universal health coverage is an important kind of policy instrument that we can use globally to try and advance some of these issues. And speaking around those social determinants of health, the SDGs, I think, provide an opportunity for us to actually really start closing the tap and preventing disease in the first place, and also making sure that, for example, the global inequalities of power in particular are addressed. For example, during COVID, many South Africa and India, for example, were lobbying quite hard for the World Trade Organization to allow us as low and middle income countries to use some of the intellectual property from the pharmaceutical companies for us to make our own vaccines, for us to make vaccines available to our own populations, and that was vetoed by some of the countries. So to me, what that says is that advocacy becomes an important tool for us to be able to provide that. So before I go to advocacy, I think we start locally and saying that, how do we strengthen our system? As I said, we have the national health insurance, and very much working within the communities, and making sure that our community-based services, we are not repeating the life as it demands again. We are moving from a hospice-centric model of care and bringing patients closer to their communities, but investing in primary health care, in community-based services, in a network of services that could be supported by specialists, but that's providing health services, that mental health services that are beyond kind of serious mental health disorders, including common mental health disorders, lifelong conditions, and focusing on prevention, promotion as well, and very much dealing with those social determinants of health. And when we talk about social determinants of health, as I said earlier, we really have to think about health advocacy, because even if here in South Africa, we can do the best that we can, we are a global community. And I think COVID showed us that we are connected and interconnected and very much dependent on one another. And so advocacy becomes an important tool and an important kind of act of love, an important act of global love, where we recognize that actually I am because you are, as I said, in terms of my own saying here as a Zulu woman. And I think we saw in COVID that even though we speak about some of these things, when the rubber hits the road, sometimes that love does not come through. And so it is really up to us, and I think as a community that cares about all of these things, to ensure that we are consistently advocating for the political agenda of health as a global agenda, as something that everybody requires in all our countries, and ensuring that we mobilize resources to ensure equity, and that there's accountable, and the commitments that we make as countries and as global players, we ensure that we can live up to them. So sorry. So I guess what I am saying I'm hoping that my short presentation to you and the story that I've told you has shown an example of when love was not enough. But if we understand love using Dr. Martin Luther King's definition of what love is as a demand of social justice and allowing the power, which is the health system, the structures of government, the institutions, to be that vehicle around which we can deliver on justice, where power can actually correct everything that stands against love. And I think we can agree that actually love that is a doing word, love that is action is enough. Love that is just words, that is when love is not enough. But if we understand love to be intricately connected to justice, to freedom and power, then love is enough. I thank you.
Thank you. Tracey, thanks so much for a wonderful presentation, and I think the passion and the power is there, but also I think we can feel the love, and I think you're going to get there. You're going to get there. So now I just want to invite down to the podium here Siobhán McArdle, Assistant Secretary, Social Care, Mental Health, Drugs Policy and Unscheduled Care at the Department of Health, to give you the right title. Please join us. And also John Farrelly, CEO of the Mental Health Commission. So we have two very important people here from Ireland, one from the Department of Health, one from Mental Health Commission, one, I guess, one who's obviously dealing in regulation in terms of mental health, but also one is very much at the centre of policy. So I'd really love if you could respond perhaps to Tracey's, I think, powerful presentation. Just your thoughts, maybe Siobhán first and then John.
Thanks, Brian, and thanks, Tracey. It was an amazing presentation and brought back some, salutary lesson to us in Ireland around our own history in terms of how we have provided care or not provided care to certain groups of people, our history of institutionalization of certain groups, be they people with mental health difficulties or disabilities, or women or children in the past. And what have we learned? And listening to your presentation brought back the sort of the importance of reform that is achieved but ongoing in Ireland. The importance of continuing that journey of moving our services from being episodic or when there's a crisis to being more connected in the community. And our Sláinte Care policy is aiming across government to move us to a place where we are providing services in a more connected way in the community, whether that be in primary care or mental health services, disability services. We've also it imposes the responsibility on us to continue the work around multidisciplinary, and by that I mean not just the different healthcare professionals, but how we connect families and service users and the voice of service users in how we do our work. So that certainly echoed for me. And I think also in Ireland, we certainly, while we enjoy, and recently in the last week, the Department of Health published Health in Ireland, so it gives us trends on how the health of our population is, and we see, increases in life expectancy, but we also see that isn't consistent across all of our population, and we have sectors of population that don't enjoy the same benefits of the investment in health, and have poorer life expectancy, higher proportions of chronic disease, and really are more likely to be at risk of other poor health outcomes. And that behoves us and across government to continue the work on cross-government initiatives that look at the social determinants of health and begin to use data and evidence, but also the voice of lived experience to understand how to engage and provide health services that are actually meaningful and provide those positive outcomes for all across our population.
Well, thanks, Siobhán. It sounds like there's a lot of parallels then in terms of your approach and the department's approach, and really what Tracey is talking about, what the aspirations are. Just in terms of the issue of that Tracey talked about, he talked about advocacy and leadership, and also this focus on primary care, which I think Tracey was alluding to. I mean, what's your sense of that?
So I think leadership, to me, across our health services is a multifaceted thing. I see that leadership is both important in a top-down, but also in a bottom-up, and it's about how we create health systems that have everybody's voice heard and understood. And I don't mean that in a kind of an empty way, but that we create structures and systems whereby team members have a voice, where families have a voice, where the voice of lived experience has a voice. And sometimes we need to back that up, and in fact we do, with rights and with the UNCRPD, which is about saying that we will move our services to a point where we can be measured as to how we're doing that against people's rights. And our Assisted Decision Making Capacity Act, which was brought in and enacted last year, also creates responsibilities on the state and also at service provider level around how we bring in and facilitate those whose voices are not easily heard in the current milieu. So I think advocacy is about small a advocacy and big A advocacy, and how we use some of that. And I think it's to Tracey's point around how we use power to overcome those barriers to love and care in our health system.
John, Mental Health Commission perspective on this. What are your thoughts?
Well, my thoughts are, I've seen this happen over my career in different countries. If you remember back to the Italian project, back in history, where someone politically or academically thought it's the institution is the problem. Let's just, if you put people out in the community, they'll be fine. And a lot of people suffered. You see it on the streets of London, where I trained, where people with mental health problems weren't given proper treatment and ended up homeless and unwell. I have to say, in Ireland, and my job is I sit, I watch, and I enforce the laws set down by our state. And our state has laws in terms of approved centres that if you're trying to close an approved centre or discharge any person, there has to be a proper discharge plan and care. So the safety mechanisms are there. I admire advocacy, I admire all the work of everyone, but I also understand in life that you're put in there as a regulator to protect and vindicate the rights of people because they may not have the power themselves. And I often wonder, do I sound paternalistic? Am I old-fashioned? But I have seen that. So I'd be more hopeful. We've learned the lessons. I used to be a regulator in older person services. And essentially there's dangers in institutions as well, where you put a lot of people together, whether that's in any sort of an institution, you can lose the individuality. And for me, there's one other point that's really important, that I agree with it depends on the context and where you live. And, if there's a political struggle or what's going on in terms of, the majority of people. But for me, listening this morning also, for me, it's about how do we create a pathway for creativity. So if we look at our regulations at the moment in Ireland, they're mainly making sure people are safe. That's the main purpose of them. We've one or two regulations around holistic healthcare. Funny enough, when it comes into care of the dying, the palliative care regulations are much stronger on creativity, on individualisation, etc. So I think we're going there. I agree with all that was said about the policies. We are going there. And in fact, we are going out into the communities now. But that movement from the institution to the communities has taken, I would say, 30 years, at a reasonable guess. But even before that, my parents worked in the old institutions. They came up from the country in the 50s and worked they were called nurses, but they were pretty much, it's about keeping people safe. So I think that is the future, but there are risks around that as well.
Before maybe getting a response from Tracey, I'm curious about the issue of regulation in the institutional settings, but also most of the people with mental health issues are in the community, and care is in the community, as Tracey said. That's where it needs to be. 80-90% of people with mental health. So in terms of rights and policies and regulation, and supports in the community. For mental health issues, what are your thoughts on that?
Well, I think we're going the right way as a country. Where I kind of feel, is this more your area? I feel a bit, but like we've some strong legislation coming down the track. Our policies are saying, you know, going out into the community, we are building that. People are realizing that. But do you see the dangers in that? It's not a danger, but there's a conflict, because you'll often hear people don't talk about human beings, they talk about beds. It's the currency of beds rather than people. When in fact, our policies and strategies are all about getting out to the communities, early intervention, building that, while still having arguments. I call them institutional arguments. So I think we're going the right way, but you're more in charge of it.
No, thanks, John. And just to build on that, I think there is an importance around standards and consistency. And we can map those into statute, into laws, but that's often not sufficient. How can a law be dynamic or flexible to provide that, like particularly in healthcare where it evolves and changes? But I think it is important that we have standards, and that means that whether you're living in one part of the country or another, that you can enjoy and be entitled to the same standard of care. And it should be more than just safe care, it should be quality that makes a difference to your life. I particularly liked Sissy's analogy around putting paint on a building, and does it change what's inside? And that there is a risk sometimes when we impose, policy alone without the change of the individuals and that agreed standard and the buy-in of people both in receipt of services and people who are delivering the services is so important. And then the accountability piece around that transparency to the state for what is an investment in state money, around what is happening with that money, in terms of things like productivity data, spending data, outcome data, though, because it's not enough to say we've got X billion and we've used X billion. What difference has it made to people's lives? And within health and in our discussions with health, they're the places we need to go more, is how do we measure what good looks like, and how do we let people know that that's what they're getting for that investment?
I might just bring Tracey back in here just to get her response to what she's hearing from Siobhán and John, and then I'd like maybe if we have time just to move into the issue of the creativity and the arts space, if we have an opportunity maybe, and talk about South Africa and Ireland. Tracey, any immediate responses to what you're hearing here from Ireland?
No, thank you very much to John and Siobhán for their comments, and I think I agree with a lot of their comments. And I think what I'd like to add also is that I think for mental health in particular, there's the issue of stigma and the issue of fear and an issue of investment. So if you consider, for example, how much is invested in infectious diseases or in acute care, for example, and I think one of the points that John made was, and I think it's the same here in South Africa, where we've foregrounding acute care. When people are psychotic or there's an acute emergency, if you look at even our Mental Health Act, that's what we are focusing on. We have mental health review boards which are there, but I do not have the gravitas or the investment or the ability to actually hold institutions accountable. And a part of that, I think, is this unconscious bias against mental health services. It's always very interesting to me that all of us really need our brains, but when it comes to investing in mental health and foregrounding it and making it a key feature of our health system in the early days before you get sick, investing in prevention, in promotion, in well-being, in community-based services that promote just mental well-being before we even get to disease. There's very little of that happens, yet all of us, we only have one brain, and it's the one thing we probably need the most for our own survival. So I think the advocacy also for me is around removing some of that stigma and globally actually making which is what I think this conversation is so important, where all of us can have conversations without fear. And I think part of the stigma is based on fear, and we can have a conversation around which is based on love rather than fear. So thank you very much.
Thanks, Tracey. I mean, I think over the course of the 3 days, we've had some wonderful examples of people speaking out against the stigma. yesterday and the day before. People, with lived experience coming here, talking, very, very brave people talking about what's happened to them, but also not just some of the tragedy and how difficult it was, but also, their ability and their talents and what they can achieve. And it's been amazing. So I think, I agree. We have to beat off stigma, and we have to defeat stigma. But I think this week has been very, very enlightening in that regard. Just very quickly about, it is Creative Brain Week, and we're looking at holistic care. We're looking at love. We're looking at care, and in a very broad way. So perhaps maybe ask the two of you here, maybe John first, in terms of arts, creativity. Where would you like to see it go in terms of your vision for mental health for the future here in Ireland?
Well, I would like to see it go in the same direction it's gone for the last 30 years, except quicker.
Okay.
So I remember years ago going around asking for counselling and people looking at you blankly. And now it's a given. You can access counselling in Ireland online very, very quickly in quite an equitable way, actually. You don't need to be wealthy. I feel it's the same about creativity in the arts and brain health. So you're leading the way, having conversations that other people aren't having per se. But can I just say, in the approved centres where we regulate, there is a strong cohort of creative people. Even though the regulations are tiny around, they're very small regulations. Creativity isn't mentioned. It's all about, people's well-being, their personal preferences. But when you go out into the centres, you definitely see the spaces for creativity, for art, for all the different things that are there. It's just not articulated. I definitely think, and in the mental health end of things in the future, there is so much going on in Ireland around, even this morning, listening to the poetry. Now, I'm just like love. I mean, I'm not a person who talks about love. I mean, I talk about...
Well, you're using that word a lot now.
Well, I suppose just to be clear, for me, like when we had the discussion about love, for me as a parent or as a son, I would see it most. But I've worked in institutions for a long time, and I think we try and get at it around compassion, around dignity, around safe care. Because I had a look, and funny enough, in the UN conventions, the only area where love is mentioned is in relation to the children, that they're entitled to grow up in a loving environment. So it seems when we get into adulthood, love isn't important. It's hard to determine. And I someone up there mentioned, that was Freud actually. The opposite of love is not hate, but indifference. And so for me, the argument isn't love. I'll tell you where I come from. The argument for me is making sure that human beings who have a tendency towards recklessness aren't reckless. So that's where I come from. And I know it's not healthy, but I do think the creative element is one way of doing that we don't do yet, and we need to do.
Okay. Siobhán.
Thanks, John. And I think the theme of the last speaker was love is not enough. And I would say, although I represent policy and strategy, is policy or regulation is not enough. And we know that when we're trying to implement changes and regulations and things like that, we often come to the point of culture where we're talking about this thing that's harder to measure and has a life of its own and is in a sort of it's just harder to define. And yet we all have a sense of what good culture would look like and what poor culture would look like. And I think into that space comes the connections that can arise out of creative interactions, and the arts and creativity within healthcare provide a mechanism for people to connect, whether it's through a therapeutic relationship or whether it's through being, participants in something that's happening in the care environment. And it is really important that we create that space and sort of at government level, as you're aware, over the last 2 years, we've had a very big increase in the number of new arrivals into Ireland, whether are Ukrainian arrivals or international protection. And within the department, we're working with the WHO Collaborating Centre in Limerick on art and dance and music and how we can engage with new refugee or migrant arrivals about how they can inform health research and policy, because we have to find ways of hearing the voice, as I said, but sometimes that voice doesn't look like the same voice we bring to the table. So I think art allows that. And we've so many examples, Brian, of where in other pockets we see some really good investment and outcomes in terms of creativity for older people, and across mental health services and in disability services. But I think we could strengthen that and create a space that speaks to that pride in that kind of culture.
I think in terms of what both you and John have said, I think we need to celebrate the successes and all the things we've done down through the years and all the really good things that are happening in terms of arts and creativity and joining it up. But I love what you say about it, because I do think it is all about the people as well and the connections, and arts and creativity can really, really foster that. I'm going to give the last word to Tracey in Cape Town. Thought, arts, creativity, and leadership?
I think actually the arts could be a great equalizer and a great tool to ensure equity, because if you think you can have people of different kind of intellectual abilities, but somehow you can have somebody who'd be thought to have a lower end intellectual ability, but have an incredible creative spirit and ability, and even be able to create more than somebody else who's thought to have higher kind of intellectual capacities. So I mean, I absolutely agree with my colleagues that I think we don't put enough store in what creative the arts and creativity can do as a tool for healing, as a tool for equity, and as a tool for connection. I mean, I was very interested in what Siobhán was talking, where she was talking about working with people who are migrating into Ireland and using the arts, because when you can't speak to each other, how many of us can listen to a song that we don't understand the words of but feel it in our heart and soul? So I think for me, I think absolutely the creative arts, creativity can be a great equalizer that we can use as a tool. So thank you very much for being part of this conversation.
Okay, so I have to bring the session to a close. I mean, I think it's been fantastic. We probably could have gone on for another half hour, but Dominic says, no, we have to stop. And I'd love to have brought in the audience, but unfortunately we don't have time. But maybe there may be time later on for some questions over lunch. So thank you once again, Siobhán, John, and Tracey in Cape Town. And we just keep the conversation going. Thank you so much. Bye-bye.